Thank you. It's my pleasure to be here and to share some information that we've gained recently related to the pathology of patients with post-deployment constrictive bronchiolitis. So I'll start with some information that many or most of you are probably already familiar with. Matt King, who is a fellow in our division, along with Bob Miller, identified a cohort of soldiers back in 2011 that were referred to them for unexplained dyspnea on exertion. Of that initial 80-patient group, 49 underwent thoracoscopic lung biopsies, and 38 were diagnosed with constrictive bronchiolitis. A variety of exposures were reported in that group that are partially listed here. Now, this is a figure that illustrates the pathology that was defined in that group back in 2011, and without going through the details, this really focused on abnormalities in the airway. These were small airways that were evaluated and clinically described as having constrictive bronchiolitis. A number of other findings were reported. They were listed in this separate table, along with some information about how often that these specific pieces of the pathology were identified in this group of patients. So what we've done is to try and take an updated look at that by looking more specifically at both the airway and the other pathology that might be present in the lungs of these patients. So what we've done is a comprehensive morphometric analysis of the small airways, the blood vessels accompanying these small airways, and the lung parenchyma in this original cohort of patients, or at least most of them, and some additional ones that we have evaluated over the last several years. Secondly, we wanted to characterize the inflammatory or immune phenotype that was present here and compare it to other disease, which we've used COPD, and I'll show you some information about that in a second. So the methods here are that we took clinical biopsy samples from these constrictive bronchiolitis patients. We have used an age-matched, non-diseased cohort of individuals who had lungs that were declined for transplantation and had no known smoking history or prior lung disease history. I'll show you a little bit of data as we go along about some former smokers with COPD, both mild to moderate and then some more severe phenotypes of COPD. And I'll use that as a comparison, but the main study here is comparing the control subjects and the constrictive bronchiolitis patients. The diagnosis of constrictive bronchiolitis was made by a clinical pathologist, and oftentimes two of our pathologists at Vanderbilt had reviewed these to make the clinical diagnosis. What we did is to get the lung sections that were available. We looked at small airways, which I'll define in a second, and to be evaluated morphometrically, we wanted to make sure that there were at least three small airways per section that were available, and we had at least 2 sections per biopsy, just to give us enough to have confidence in the findings. We then evaluated all small airways, and that definition of a small airway here is a membranous airway less than 2 millimeters in diameter, and we then evaluated adjacent arterioles as well. On serial lung sections, we did a variety of stains to look at pathology, as well as Pica-Sirius red to look at collagen, and trichrome to look more comprehensively at extracellular matrix. We then did some immunostaining for markers of different cell types that I'll show you as we go along. And I should mention before I get too far into this that these were clinically done biopsies. So the lungs were not inflated, and in order to normalize for the individual size of each airway and vessel, we normalized everything to basement membrane length, which has been the standard now for non-inflated airway lung samples. Okay, so this describes the clinical characteristics of the subjects that we evaluated here. We have 19 lifelong non-smokers that we had explanted lung tissue from. Their average age is 37. You can see that there are more proportional females here than in the soldiers with constrictive bronchiolitis. We list here the number of airways, and you can see the basement membrane length is about 1.5 millimeters, showing that these are really small airways that we typically see in these biopsies. In addition, we evaluated similar numbers of arterioles in controls and constrictive bronchiolitis patients, and then we list the interalveolar septa because we use that to normalize the amount of parenchymal tissue that we evaluated for making capillary measurements and also collagen deposition in the parenchyma. Okay, so to begin with the data, I'm just showing you some examples of what these small airways look like in non-disease controls where they uniformly look, for lack of a better word, normal. In the constrictive bronchiolitis, however, there's a variety of different appearances. And so just by visual scoring, we first separated them into normal, moderately abnormal, and severely abnormal. And you can see examples of those in H&E and trichrome stains that are shown here and here. So these are severe on this side. And then I'm showing you the visual scoring because I want to make the point that the majority of these airways are abnormal. So over 60% of them were defined as severely abnormal, suggesting that at least in the sections that were evaluated, this is a widespread abnormality. Now, interestingly, when we look at the airway volume density, so this is a core measurement where we look at the wall thickness of the airway divided by the length of the basement membrane, there is no difference here in the constrictive bronchiolitis group compared to the controls, which is interesting given this appearance and the definition, by the way, that there's fibrotic remodeling to make this call. So what does this mean? Well, I'll show you what it means in several different ways, but first I want to make a comparison to COPD. And so this is another set or a larger set of controls in the constrictive bronchiolitis group, and then moderate COPD and severe COPD. So this just shows the airway wall, and you can see how these are different if you compare to the controls here. And then I'm also pointing out these are alveolar attachments where the small airways are tethered to the surrounding parenchyma, and I'm going to show you that's important in a second. So when we do this VV airway measurement, you can see again there's no difference between the constrictive bronchiolitis and the controls. However, in COPD, there's a progressive increase in airway wall thickness, which is well described in the literature. Interestingly, the alveolar attachment numbers are also similar here in constrictive bronchiolitis, and those progressively are reduced in COPD, and of a variety of pathological parameters that we evaluated, which I won't show you all here. This is by far the best predictor of FEV1. In fact, you can see that the R is 0.83 almost when we do FEV1 compared to the mean number of alveolar attachments of these small airways per group. So suggesting that part of the reason that constrictive bronchiolitis might not have obstruction is because the attachments are normal. So the airway remodeling in constrictive bronchiolitis is different than COPD, but it is nonetheless abnormal. So this slide shows collagen and smooth muscle evaluation as well as elastin in constrictive bronchiolitis samples. So this is picoserous red staining here, and this in the inset you can see that at the higher power that there's more red here than here, and elastin actually shows the opposite, so less red here than here. And this is quantified as percent of the airway wall occupied by collagen up until the elastic, the smooth muscle layer. So there's a marked increase in collagen despite the fact that the airway is not thickened. Elastin is decreased, and this is a volume density measurement of smooth muscles showing that smooth muscle hypertrophy is present. So these airways really are narrowed with a thick band of collagen and some increased smooth muscle surrounding them. So when we looked at the immune and inflammatory cell influx, we first looked at lymphocytes. That's been reported in a variety of chronic lung diseases, and we had seen some that were reported lymphocytic infiltrates around small airway walls in the original paper. So we did CD4 and CD8 staining, and we quantified these again using the normalization of the membrane length, or the length of the surrounding basement membrane. When we looked at CD4 cells, you can see in constrictive bronchiolitis, they're increased substantially compared to the non-smokers, and at the same level that we see in COPD. Same's true with CD8 cells. You can see that the CD8 cells are increased here, similar to COPD. So lymphocytic influx and inflammation is a component of this. And when we looked at tertiary lymphoid structures, or what's been called BALT, or these areas where there's accumulation of B and T cells surrounding small airways, this is an example of one here. A large percentage of our airways in constrictive bronchiolitis patients actually have an adjacent follicle. In COPD, it's interesting because it's been reported by several groups now that these tertiary lymphoid structures are only present in severe COPD, so not the early stage. This seems to be something that's involved with progression, but also present substantially here. Now, COPD is also a disease where there's innate immune infiltration as well as lymphocyte infiltration, and so we measured neutrophils by neutrophil elastase staining. And when we measured neutrophils, you can see they're not present in constrictive bronchiolitis. However, we see a substantial number of neutrophils in the COPD group. So some similarities in terms of immune cells, but clearly no neutrophils. And even though they're harder to quantify because of their location, we didn't really see a difference in macrophages either. So I want to shift now for a few minutes and talk about other pathology outside the airway. So we evaluated small arterioles in addition to the evaluation of the airways, and this just shows a picture of an abnormal small vessel in constrictive bronchiolitis compared to the non-disease control. So the way we morphometrically evaluated these are to look at the total diameter, which is the diameter of all the way across the measuring at the edge of the adventitia, divided by the luminal diameter, and that gives us a measure essentially of of vascular wall thickness. And what you can see is that there's a significant increase in the constricted bronchiolitis group, and when we look at the volume of the smooth muscle, which is mostly in the media of these vessels, then you can see there's an increase there. So there's smooth muscle hypertrophy in the vessels as well as in the airways. And then we looked further out in the lung parenchyma, and we did CD31 staining to look at capillaries, and we measured capillary area. And this is a measurement of capillary area here. And what you can see, which is pointed to by these arrows, is there's area in the interalveolar septa where there's capillary dropout. And this is in the range of 15-20% reduction that we see in the constrictive bronchiolitis patients. In addition, although I don't know how well it projects here, when we do picoserous red and quantify the red in these septal areas as well as elastin, what we found is that there's increased collagen and increased elastin in sort of linear deposit in these interalveolar septa, and that's quantified by this LD collagen and elastin measurement here. So the septa are abnormal as well in that there's loss of capillaries and some, while not overtly fibrotic, some areas where there are increased deposition of collagen and elastin. So to summarize, soldiers with constrictive bronchiolitis have widespread small airway pathology. They have increased collagen deposition and smooth muscle hypertrophy. There's vascular pathology present as well, and that includes arterioles with medial hypertrophy and some septal capillary loss. Linear deposits of collagen and elastin are present in the alveolar septa from lungs of constrictive bronchiolitis patients as well. And then on the immune inflammatory side, we see a lymphocyte influx and a marked increase in these tertiary lymphoid structures in the post-appointment constrictive bronchiolitis patients. So in conclusion, while constrictive bronchiolitis is how we made the clinical identification here, the pathology that we found is more broadly present than that and involves the airway, vascular, and alveolar compartments. Additionally, I think it's important to point out that the post-deployment constrictive bronchiolitis patients have adaptive immune activation, which suggests to me that there's potential for disease progression, since presumably this has been going on for a while at the time that we identified this in biopsy. So just to finish, I want to particularly mention the people who did this work. Vasily Polisukhin is an airway pathologist who's worked with me for many years, who led the study funded by a DoD grant. Bob Miller has helped provide these samples for us, and some other folks in the lab have done a lot of the immunostaining excuse me, and quantification. So with that, I think I'll stop, and I'd be happy to take questions. Thank you.
Thank you. Very nice slides. Impressive pathology. Comments, questions?
I guess as the pathologist in the committee, how were the control samples fixed? Were they perfused, fixed through the bronchus?
No, none of our samples were. So the explanted lung samples, some of them were obtained from the University of, from UCSF.
That's where I work, and I tend to, the ones that I prepared for Lorraine Ware in the past, I perfused through the bronchus, and that would change the density of the alveolar parenchyma and change the dilatation of the capillaries.
Yeah.
Strangely, if you perfuse through the bronchus, the capillaries balloon up, which is somewhat paradoxical, but happens.
So thank you, because I was going to say I wasn't sure about the ones we got from UCSF, but the ones that we've done at Vanderbilt, which are the majority of the controls, we haven't perfused and have just formalin fixed them similarly to the way that they were fixed in the.
But they're whole lungs, you're saying?
Well, so we get them out as whole lungs. Although a variety of things happen to them, we get small pieces that are then fixed and processed and stored, and a variety of other things happen with those lungs.
Because for the small airways, for example, we can use measurement of the basement membrane that you said to help control for issues of ex vivo contraction of smooth muscle, for example, but it's difficult to do that in the alveolar tissue.
Yeah, that's for sure.
I'm slightly off the subject here, but have you compared any of these CB cases to asthma? Asthma mortality, perhaps, I guess you'd have to deal with in terms of the same size airways.
Yeah, so we don't have much data on that, but I'll tell you what we know is that we've got a few samples from Sally Wenzel. It's just hard to get these samples, and they have tons of smooth muscle hypertrophy around these small airways and lots of inflammation, but we haven't done any morphometric evaluation. We only have seen just a hand. We've got probably 4 or 5 of those, so not enough to say much about.
Would you say they look more like the CB than?
They're far more inflammatory and really more profound smooth muscle hypertrophy than anything that we see here. And that's also compared to the COPD group, by the way.
And that's actually kind of leads into my second question. After doing morphometric analysis of the cases from the original study, how often did you decide that these were in fact not obliterative bronchiolitis or constrictive bronchiolitis? Because, you know, the definition, I think, was somewhat different in the New England Journal paper as to what kind of an agreed upon definition of, say, from the Brazilian paper that was quoted in that paper.
Right. So, so what I would say about that is we haven't gone back to re-adjudicate the diagnosis. We took all the samples that we had access to so far from samples where that diagnosis was made by our clinical pathologist. So, so I think that could certainly be a point of further discussion. However, what I'll say is when we look at these airways, I mean, I'm no pathologist, but I can tell that, I mean, can't really blind these because these are obviously different than the control samples just by looking at the small airways. So I think, again, I'm not sure I know exactly when you get to constrictive bronchiolitis and when you don't, but most of the airways in these samples that we looked at are abnormal by a variety of parameters.
And the problem is, I am a pathologist, so when I look at the pictures that look strikingly abnormal, it looks to me like what you see in normal small airways with ex vivo smooth muscle contraction. So what I'm looking for, instead of seeing that scalloping of the epithelium, which looks very dramatic but yet is an artifact, I'm looking to see if there's increased collagen deposition or pink above the smooth muscle layer but below that epithelium.
Yep.
And it's a little less striking in these examples. And when you compare it to the normal, which many of the times are perfused through the bronchus, it's going to be a dramatic difference that I think is visually very striking. But like you said, when you did your actual analysis, there was not a difference. So using kind of a visual, this looks severe, I would not recommend doing it in a surgical biopsy.
Yeah. No, I think obviously if we had a better option, we would have a better preserved sample. But I would say two things to that. One is we have COPD samples done exactly the same way, and this is not an issue in the COPD samples. So that's one thing. And the second is, that's the collagen measurement that we showed, which is this percent collagen measurement, which again, I mean, we could discuss the details of that, but that is exactly the collagen between that basement membrane and the smooth muscle layer that we evaluated.
I thought you said that it was in the entire airway. Is it actually between the smooth muscle and the basement membrane?
Yes.
So it's not including the smooth
The
muscle
collagen measurement
and the
is not.
adventitial?
Yeah, that's right. Sorry, you're right about that.
Just a couple of questions. I wanted to ask about the moderate severe kind of designation, how that was defined, and I also wanted to ask you about the pleura, and then the other thing was where the samples were taken from in terms of lobe, because we've seen some variability between the upper, middle, and lower, and I wonder if you thought about that.
Yeah, so I'd have to get back to you about the location because they're somewhat variable, and I'm not sure about that. In terms of the COPD severity, that's based on GOLD criteria, which is degree of obstruction, is how we identify those. So
that was just based on the degree of COPD.
So that's the COPD breakdown that I showed you. There was the one slide at the beginning that had the visual assessment, and that was basically just using those examples that I showed that our pathologist, before doing the quantitation, sort of did an overall how many of these look abnormal kind of evaluation.
And then the pleura?
Oh, the pleura. So the pleura is clearly abnormal, at least in some of these. There's some collagen deposition, some fibrosis below the pleura. We don't have pleura or much pleura on many of these. There's also some increased vascularization around there, like you see with some other diseases that cause pleural scarring and thickening. So it looks abnormal. We haven't looked at it in any more quantifiable way.
Thank you very much.